Hello, everyone. I'm just going to give it a couple minutes for people to log in, and then we'll get started.
Hello, this is Derrick Heldt-Alvarez. I'm the Director of Revenue Cycle at Detroit Medical Center, and welcome to our talk today. We are going to be talking about establishing a transparent and consumerist patient access strategy. And with me are fellow panelists.
Hi there, my name is Kaylin Blair. I am the Senior Director of IT Applications for LCMC Health, a 9-hospital system based out of New Orleans, Louisiana.
Hi, my name is Achil Khan. I'm the Director of Revenue Cycle and Decision Support at KSB Hospital. We're a small, independently run not-for-profit in Northwest Illinois.
Hi, my name is Ashley Toney. I'm Director of Revenue Cycle and also wear the hats of privacy and compliance. I work for Atrium Health, but am also located at a small critical access hospital in North Carolina, St. Luke's Hospital.
Hi, I'm Linda Kolhanek. I am the SVP and CFO at St. Luke's Health, which is a Texas division of Common Spirit Health, and I'm based in Houston, Texas.
Awesome. Well, thank you guys for your introductions. So as I had talked about today, establishing a transparent way to help our patients at the end of the day is what we're all here about. And we have developed some questions that we're going to talk about today. And so the first question we have is, what successful adjustments have you made to your patient access strategy to keep pace with consumer expectations and overcome the traditional barriers? Do we have a panelist that would like to lead off?
I'll be glad to. As simple as it sounds, we realized and accepted that what has worked in the past doesn't now. We felt that we should try to shape our consumer expectations to not to our process, but vice versa. And we really have tried to create a culture to foster change and excitement around change with teammates. I think a lot of the times they've maybe felt left out of the process when, in all honesty, they're seeing the patient every single day and they know maybe some of the better ideas. We wanted to make sure that our teammates were keeping at the top of mind that really patient access's mission, and really all of Revenue Cycle, is that we help patients and their loved ones so they can focus on their well-being. And so we're trying to take care and have that burden for them. But then also to recognize how these interactions are different. You're not scared when you go to Walmart to buy a loaf of bread. It is a very different interaction. So how is that? So we want to make sure that we empower the teammates to identify opportunities in a different kind of way. Some of those changes included changing how and where the patients, we interact with the patients for patient access, for registration, estimate delivery, et cetera. And then also from the estimate delivery portion to identify what patients need to understand, to create clarity around the estimates, and then also for them to make an informed choice.
Awesome.
And if I were to add some color onto that, I think Ashley touched on it very aptly, is trying to get some things out of the traditional way. The way we've been doing things might not necessarily be the best way. So taking care outside the 4 walls. We all can agree healthcare has been come to me at my office in my brick and mortar location, but patients demand, that they want more digital access. And so leveraging things like the patient portal, we now have gone to appointment reminders with bidirectional communication, a lot of the pre-service financial conversations that Ashley mentioned with estimates and your patient responsibility. And then, looking at real-time eligibility tools, what information that can that give you to do those estimates, and then on the back end, flexible payment options. I'm sure we'll talk about online self-scheduling at some point. But again, just activating the patient, putting more tools in their hand to have them take ownership of the care creates a better experience for everyone. It allows our staff to work on more meaningful products, because at the end of the day, that's the most important thing, outside of the patient, keeping the staff engaged. And so by activating the patient, we can get the staff onto more critical thinking functions and make everyone happy.
One simple thing to add to all of that is that we added e-check-in at our sites, our physical locations. And so that helped, in addition to getting all the information collected in advance, just making it very quick when the patient actually arrived. And it really allowed for a quicker registration process that our patients were demanding.
I think it's efficiency, and it's also just trusting the patients, right? I think we really came in, and this is kind of pre-pandemic, pre-No Surprise Act, with this apprehension that we as staff knew more about what the patient needed than the patient. And by trusting the patients more, by giving the patients the tools that they can look for themselves, that they can pick their time, that they can look, with estimates at, we've got multiple hospitals that charge different prices for certain things, that they can decide, hey, I really want to see a provider sooner, so I'm going to go here, and now I know how much this is going to cost me. Or no, I'm empowered to see that this is what this looks like, and I'm going to make that decision for myself. I think has had a huge impact, and really has just shifted the mindset of the industry of, no, like, we should build the system, we should make it easy for the patient, but ultimately the patient should be in control of the healthcare that they receive and how they receive it.
Yeah, that's so key in ensuring that we can get patient engagement. Having them empowered definitely will help that. One question I actually had, Kel, you had mentioned bidirectional communication for some of this. Can you talk a little bit about how that works? Like, are you reaching out to the patient, they're responding, and then you're asking follow-up questions, or?
Yeah, no, absolutely. So the first form of this came in the patient portal, where you could look at lab results and look at different clinical indicators and message the team back. A little bit clunky, kind of more of an email type thing, send it back, and you have to check the portal when you get responses back. But more recently, we launched appointment reminders. So when we talk about technology, right, as revenue cycle directors, CFOs, I think the most important thing we can do is fill up our appointment slots. But more importantly than that, possibly, is making sure that we reduce the no-show rates, and those who have made appointments, they keep their appointments. So we launched appointment reminders that go out 5 days before your appointment with a very simple Y or N to confirm or cancel. And if you don't reply to that, you get messages, in the days leading up, 2 days before, 1 day before. And you always still get that message, whether, once you've confirmed to, remember to bring your insurance card, your ID, your form of payment for any applicable copays. And in that text message, it's not just one directional where you're just doing it and done. You can message back, hey, I can't make that appointment anymore. Can I move it around? And we have staff members across the organization reviewing those messages to engage with that patient, to ensure that we're getting them the information that they need. We're getting their feedback to set up and tailor the care experience to them. And so you got to be a little bit careful as you start to get to more clinical questions. You need to bring in, nursing staff to help support that. And we might shift things over to, we're a Cerner shop, so power chart messaging to get the messages over to the clinical teams. But anything as it relates to getting into their appointment or generating an estimate, educating, or any type of financial counseling, we're starting to see folks call less and text more.
Awesome. So our next question that we have is, with these changes, things sometimes don't always go as planned, or how you have to, reevaluate the approach that you're going to take based off of what your initial thought process was. Are there steps that you had to take to backtrack, or, of course, now that everything has been implemented, from what you guys have talked about, are there things that you would like to take forward, possibly, in hindsight, where you'd be like, oh, next time we implement something, we need to think about X, Y, or Z, things of that nature?
I would say for us, like I said before, we definitely had some hesitancy on some of the electronic patient-facing patient engagement tools, and between the pandemic and the No Surprise Act, where it just really changed the approach that we took to how we did pre-registration, how we communicated estimates with patients, and it kind of lit a fire underneath us. And so it while it at the time certainly didn't feel like it was a pro or that it was a benefit to us, I think that it moved us in the direction of getting a whole lot more implemented, really relying on the system, on our EMR, which we're an Epic shop, and using the tools that Epic provides to accomplish those things without, we didn't have the staff. There was no way that we had the manpower of patient access staff to do what we needed to do, especially with NSA. And so I think, in retrospect, it would have been great to do it more on our own timeline and not on the federal government's timeline. But it ended up working out. And I think ultimately we got to where we needed to go. One of the things that we've implemented and as part of our online scheduling initiative and some of the things that we're just doing again on making things more patient forward and giving the patient the power to dictate how they're receiving healthcare is that we do patient acceptance testing. So we've always had user acceptance testing, we've had IT testing, and now we bring folks in of saying, you're not looking at this as a practice administrator or as PAS staff. We need for you to look at this as a parent that's scheduling an appointment for your child, or this is you paying your own bill. How can we move things around to make this a better experience for you? And that wasn't something that we did initially. And I think that we didn't get the initial engagement and success that we wanted to, because we were really looking at it from an operations and IT standpoint and changing the approach of saying, how does this look as a patient? How does this look as a parent? Can we make the fonts bigger? Is this wording just confusing that you don't actually know what to click because you used IT lingo and that's not how, or you use lingo that's how we communicate, has really proven effective. And I think something that people honestly look forward to doing now, and has given us a really different approach to when we do roll these things out that are patient facing.
Wow, that's pretty amazing that you're able to integrate patients into the process. It's all about engaging them. So great job.
One thing when we implemented our e-check-in process that we found is that we kind of left out some of the pre-work around consent forms and coordination of benefits. So that was it was an improvement in the second round where we actually fixed it so that the patients could sign those forms before they arrived, and that alleviated some of the logjam that we found as we had publicized the e-check-in process. It wasn't completely E at first, but we fixed that.
On the bi-directional communication, the topic from earlier, a couple of things we learned in that process. Again, the language is really important. I can't, a 2-sentence text on "thank you for confirming, we're excited to see you. Please bring your, copay ID." I mean, we spent 2-3 days just crafting those 15 words to make sure that it was as clear and effective as possible. But what we learned after the fact is when patients accidentally or intentionally declined or want to cancel their appointment, it was canceling the order and the back end since it was integrated with Cerner. And when you've got outside providers who are ordering and sending folks to your facility, that can be difficult to go back and re-get that order, re-sign it, reattach it to the encounter. And it gets especially frustrating when that was all done in accident. And it would even cancel the appointment slot. And we've got a long waiting list, a longer waiting list for some of our diagnostics. So when folks are calling and our central scheduling team is looking at available appointment slots, one opens up. It wasn't intended to be open because someone accidentally hit no instead of yes. And so then you had the patient confusion on rescheduling and moving folks around. So that was something that we learned on the bi-directional communication, the texting platform. On another front, when we rolled out copay collections, obviously you wanted to do copays. It's part of the contractual obligation with the patient, the insurance, and ourselves as providers. And during COVID, you kind of pause it because you did not want finances to be a barrier to receiving care. And we know, and a lot of folks don't receive care because of ambiguity or uncertainty over the cost. When we got out of COVID, we got back to collecting copays, and we had to battle through inconsistent messaging from one location to another, or "you never asked me for that before. Why are you asking for me now?" And in the ED, we even went as far as looking at the level of care in the ED and developing protocols based off of level 4s and 5s. We'll do this protocol. 3s and 2s, we'll do this. Level 1, we're going to change the approach. Really involving the clinical teams in the rollout for our copay collection. So if we could go back, obviously with the bi-directional communication, understanding the implications of canceling the appointments, and then on copays, ensuring the consistent communication, the proper training, and involving clinical teams where appropriate.
I would say for us, we mentioned the part about registering and how patients interact, there's a lot of times we look at it and we think about certain things. Some of the items that are harder to change, real estate. Okay, so you don't have a front location. How do we get creative about doing that? Okay, you don't have a plug here. As simple as that sounds, it does become a barrier when you can't change the infrastructure of your facility. And then also staff, it would be great to have someone up front and at, every door, but when you don't have enough staff or someone's out sick, what do you do? How do you pivot around? On the estimate front, we really wanted to be transparent. We found that there was a lot of patients that didn't understand that. However, what is too much information? You can provide too little, you can provide too much. So there was times where we were providing too much information that maybe they didn't understand it. And so it became a catalyst for complaints when maybe it was just a whole misunderstanding. And then also contacting the patient too far in advance. We were really excited. We went ahead, we got you scheduled, we have everything taken care of, but your benefits could change a little bit depending on what time of the year this is or what services you had this done. Or, and patients would get really upset saying, well, I went here, I had this. So that was a big thing. And then from the authorization standpoint, I don't know how everything we're having to pivot on. And I would say that's the thing I would say the very most. We're having to pivot on everything. Authorizations change yesterday and it'll change tomorrow. You could have non-clinical staff doing authorizations consistently at one point in time, where now that's not always the case. So again, we're just trying to take a look at the clinical and the insurance guidelines to be able to pivot to what we need to do now.
Yeah, one of the things that I know has changed for us is being a multi-facility location is we could have an authorization, but if we have an authorization for hospital A and the patient ends up going to hospital B, that's also something that can be a little bit of a challenge.
Yeah, we've found that. And then also just changing the dates of service and, anything with authorizations. And, I think that's the constant game that we're having to play of, obviously we're working with an industry that benefits from not paying us, right? And kind of figuring out, okay, how do we safeguard ourselves as much as absolutely possible, especially when we do give the patient now more room and you're making it easier to change an appointment or change a procedure date. And if you got a prior auth for a specific date and a place, and now if you're giving the patient the ability to both cancel and maybe change to a different location, and maybe one was a provider-based clinic and now they're going to a hospital-based clinic. And again, it's finding that balance. And I think all of those are lessons learned of things that you don't necessarily think about when, again, you want this approach of we want to give the patients these options. We want to make it easy. We ultimately want the patients in the door. So how do we do what we can to make it better for the patients? But yeah, when it comes to ultimately getting paid for those services, and still having the staff that are doing that, it takes away some of those checkpoints that you had before, especially like you were saying, Ashley, with prior auths, definitely makes it more complicated.
We have a couple of, I got 2 contracts on my table right now looking at on the authorization front, this attended automation for like robotic processing for authorizations, right? We'll talk about the rules switching up and the website layouts changing out, but what I've seen, at least in demo so far, and I think this technology is quite promising, is the ability to look at the code, look at the venue type, look at the patient indicators to determine, do I need an authorization or not? And if you do, the technology can even go as far as logging you into the website, tapping in the patient's name, date of birth, member ID, group number, getting all the way to the clinical questioning for medical necessity. Then you got to touch the mouse, answer those questions, and go through. And it's cutting down the auth time by half, if not more. But then the challenges always are the rules changing and the website layouts moving around, so that these AI has got to move around and adapt. But I think this technology is pretty promising because it's taking those mundane tasks of, okay, what portal is it, Availity, Evacor, logging in, typing this information, cutting that time down in half, so our staff again can do things more on the critical thinking front. I'm here in rural Northwest Illinois. It's hard for me to attract talent. I've got to keep the folks that I've got engaged and find the work meaningful. So that's one technology we're looking at on the authorization front, because we know patient access is the start of the revenue cycle, and we've got to get it right up front to save a lot of work on the back end.
Very true. I always like to think of patient access is they're the greeters. They're the front face of our hospitals. Usually, that's the very first interaction patients have. Is with somebody in patient access, or somebody at the front desk if it's a volunteer, a greeter, something like that. So that sets the tone for the entire experience the patient has.
When we rolled out our copay training to get that standardized messaging, you nailed it, Derrick. That smile or the lack thereof is the beginning of the healing process. So you could be having a bad day. A lot of things could be happening, but that patient is coming there with a lot of fear, a lot of uncertainty, looking for answers, and your smile begins that care journey. On the flip side, the lack of empathy or the pointed questions, closed-ended questions on various elements of it can begin a dissatisfaction. And you could receive the best care possible from the clinical team, but if you didn't get that smile up front, your experience was bad. On the flip side, you could be greeted and valet and everything great and got the wrong medications and the wrong advice, but you get the Press Ganey, you had a great experience at the facility, right? And so perception is everything. And yeah, you're right. The healing journey begins with the patient access professional smiling. And so that's what we pushed out when we did the copay training, and so far so good.
Awesome. Yeah, it really does go a long way. A smile definitely, just taking time, patients, you never know what's going on, in their life. And sometimes, they have, they're going for, a treatment that, they just got devastating news. And that's where they're going, is to talk, with that, the staff there. So it definitely is very, very important that all of us, help participate with that patient journey and giving them the best experience possible. Thank you guys so much for those conversations. Our next part that I would like to talk about is high out-of-pocket costs sometimes pose significant obstacles to healthcare access. Have there been any improvements that you've been able to introduce to patients' financial experience, especially concerning upfront estimations and billings, to help streamline the process and make it more user-friendly and profitable for your organization?
I'd say the biggest thing is patients being, I talked about this at the beginning, but just the ability that a patient can get their own estimate, that even before, we've got shopper estimates that we have that you can go onto the website and you can look before you even schedule an appointment. So while that doesn't reduce the cost, it makes it available to them so that they know going in. I think at least having that information, not being surprised either at the point that you're checking in or 2 months down the road when you get a bill, that information is available and is something that the patient can digest, can look at, can poke around with without having to interact with someone, without having to feel embarrassed about talking to someone about the cost, about, when you're scheduling a procedure for your child, that the last thing that you want to do is to feel like you're also asking this person, well, how much is this going to cost? And just from a humility standpoint, from an embarrassment standpoint, like that's not, you don't feel good doing that. But by giving patients, parents, the ability to have shopper estimates, to look at those things up front, I think that has at least changed the mindset that it's not a secret, that it's not, I'm going in and I have no idea how much this costs. So I think that's been a big thing. Our other thing that we've recently implemented is that we have self-service payment plans. So again, taking away the need to talk to customer service to set up a payment plan, that at the point of receiving that first statement, that the patient can go into their patient portal and they can, we've got minimum terms, we've set the same conversations that you would have with a customer service agent, you're now able to do yourself. And so again, it's empowering patients. And while the costs certainly haven't gone down, and I don't know that they're going to go down, at least that information and that ability is there. And without having to speak with someone, of course, we've got customer service agents that are available to help when there are bigger questions. But it feels better, I think, for patients and parents to have that ability on their own.
Yeah, we've always had the payment plans after the fact, but upfront has been really very helpful to make sure electronically, again, not having to talk with anyone, just being able to calculate it online. But from a profitability standpoint, really doing a propensity to pay discussion upfront, just to make sure that we offer the payment plan to those that need it and not necessarily to those who don't. So that's been one thing that we've done to kind of distinguish that from the manual process that we had.
I think what Linda just said there is incredibly important, right? Screening for financial assistance and charity up front, which would then reduce the amount of time you're chasing pennies on the back end. And ultimately, as revenue cycle directors, our role is to reduce our cost to collect, right? And we want to make sure that we're as streamlined as possible with that. And you find out 120 days after the visit that they qualified for some percentage of financial assistance. If you knew that up front through those propensity to pay tools, I think that would save a lot of time. And what we're doing at KSB is trying to shift as much to the pre-service as we can. Again, activating the patient, self-service on the estimates, though I think that technology still has a ways to go. And on our end, we can obviously, if we know the CPT code, punch it in and get the estimates. But for the patients, how are they going to know what the CPT codes are? So what kind of UI, user interface, do they have to, from a drop down, select to the best of their ability what they're about to receive and then get the estimates on it, but then understanding that it is an estimate, the ability to follow up for that. I've heard of a health system, and we're going to look into the opportunity over here ourselves of with the global billing for an OB visit, you get hit after the delivery, you get hit with a multi-$1,000 bill. Well, could they start to take chunks off of that throughout their pregnancy so that when they get their bill, it's a lot more palatable? And how do you structure that, and how do you go about doing that? Operationally, we'll look into, but I think it is, people do enjoy the budget. They do, especially some of our older population enjoy breaking that up. And with our real-time eligibility tool, we are able to estimate the patient responsibility after the services are provided. You get the copay alert and you get an estimated patient financial responsibility. In a subsequent phase, sometime next year, we hope to be able to say, would you like to pay a portion of that? Because selfishly, when that doesn't go on a statement, the statement vendor is not collecting commission on that. We collect it up front, realize dollar for dollar every penny there. And then the patients, we believe, will be more apt to pay their bill in the first statement cycle or two instead of waiting longer in that process, therefore increasing the cost to collect.
I do think that it's important, even if you don't use the resources, that you know that they're there. Somehow, I think that creates comfort. Let's say you're not able to handle things until 11 o'clock at night. You don't know necessarily whether you need to use that resource, but you feel comfortable that I can do that, and you can follow that healthcare journey that way. We've really tried to make sure that we're building the trust in the hospital, and that's a seamless experience with patient access, with financial counseling, everybody being on the same page, but even the consistent message among all areas of care. Because it's one thing if you're seeing a doctor and you say something about it and they're like, well, I don't know, that seems expensive to me. All the work that you've done toward that, it discredits that. So we're trying to make sure that we have a very consistent message. Even if they don't know how to handle that, that's fine. Send it to us, but let's make sure that we're on the same page with the consistent message.
Yeah, I think technology has gone so far, which is wonderful. I mean, I think back to the days when I was the first of the director of revenue, I was the estimator. Patient access would call me, and so I had to look at contracts and figure out what amount patients were going to owe. Some of it is getting to know the population of the patients that you serve. Sometimes there are people that like to have those face-to-face conversations, and there are other times a lot of people would rather just be able to do it online, via their phone, even just their computer. And being able to offer those options, I think, are so valuable for us to be able to use as tools. I know for us, one of the things that we did, especially with the pandemic and a lot of these high deductible plans, we really do try to work with patients as best as possible to help them. So what we've done specifically is we've engaged our team that helps with like Medicaid, trying to get people Medicaid, for instance, or possible charity care. In the event that they are self-pay and the procedure that they're going for is $10,000 that they would have to pay. And then working on, payment plans for patients that have the high deductible plans. One of the things that I look for specifically is the patient engaged and willing to participate in their care financially? When patients are, coming to the table and, well, I don't have all this money, but I do have this and I can come up with a payment plan. That is definitely a lot better than, well, I didn't bring a credit card, I don't have any money on me. So those type of things, I think also go a long way, is things that we can do to help, engage those patients up front, helps us in the long run, because then we're not chasing after those pennies on the back end. And that is something that I found very valuable. And we've actually seen some pretty good success rates with that, where we're able to increase our upfront collections.
One of the first things I did when I took over the role was look at the average patient responsibility balance. We had in-house payment plans up to $2,000. After that, you'd have to go to a bank partner and take an interest-bearing loan. We noticed that most of our balances were underneath $5,000. We moved that threshold up to $5,000, that you could do payment plans in-house. Again, reducing the friction, avoiding interest. It's the right thing to do for the patient. That was evaluating your payment plan options, your average balance, and making sure that there's some connection over there, I think would be a low-hanging fruit.
Definitely. Our next question is, should come as no surprise, but how did the no surprise billing initiative force your organization to adjust, and what practical lessons have you learned from the experience, either positive and negative?
That was a good dad joke over there, by the way, Derrick. I appreciate it.
Oh.
The logistics around how to meet the regulatory requirements, I think that we knew certain things, but there are things that will be coming in the future that will be difficult due to system capabilities and how we interact. So I think that is tough. We don't have an issue being transparent. We want to be able to provide patients with this information. But for us, our biggest barrier is the patient perception. So for them, it's no surprises billing is, I'm surprised by my bill. I don't feel I should owe it. So therefore, you're not being compliant. And I think that confusion angers people quite a bit. And they feel like you are just ripping them off, for lack of a better word. And then their trust around the entire situation is to naught. We're trying to figure out how can we change the perspective of that. Is that more education, that we truly want to help you? We are not here to rip you off. We are here to be a partner in your healthcare. And something that we are looking to do, and we haven't done this yet, but is almost a patient advisory board, to be able to bring people in house, say, here are some situations, how would you want to see it? To be able to better address to how can we get away from this idea that the hospitals are out to get you.
Yeah, I think that's a great point of the purpose of the No Surprise Act and the perception of the No Surprise Act. And kind of what the optics and, even as a consumer, like what I heard on the news about it, and kind of what the reality was for us as healthcare practitioners, like wasn't exactly in line. And so I think we're still struggling with that of, not saying that we're not going to surprise you with it doesn't mean, again, that it's still not an expensive test. So we're giving you that information up front, but that doesn't mean that it's any less frustrating that you have a very high deductible, or that this just is a very expensive procedure. I think, I spoke on this at the beginning, but for us, kind of what it forced our organization to do was to implement a lot of things that we had kind of pushed on the back burner for a while and said like, oh yeah, we'd like to do that, but we're a little nervous about it and we're not quite ready for it. And then with No Surprise Act, we had to do it because we had to change our approach for pre-registration, because just the way that our system worked is that we had a whole lot more that appeared to be self-pay patients, which we had to get an estimate out of the door, within 72 hours, but they weren't really self-pay. We just hadn't gone through the pre-reg process yet to attach a coverage to that visit to say that they're not. And so we had to again, change how we approach it, how we are doing that registration at the point of scheduling. Or again, what can we automate? What can we use real-time eligibility for? What can we use just more systemness, where there was some distrust of that before, and it just came to a point of we don't have registration staff to go through and send out estimates for 15,000 patients a day. Like that's just not, that's never going to be our reality. And so, like I said before, it was a bummer to have the federal government give us a timeline and dictate what we were going to do. Ultimately, I think our system is better because of it. But I think our lesson is more of, hey, if you feel like these things are happening or are coming, do it on your own timeline. Let's get in front of it before we're told that we have to do it. And now it feels like a very different type of implementation.
Yeah, one thing that we experienced was, in addition to having to speed up some things that we hadn't necessarily planned to do right away, is that we found out that the No Surprises Act really caused kind of a backlog in terms of this dispute resolution process. And really, I think we're looking for hopefully new federal rules that'll help us as we go forward to make sure that those timelines for getting the responses from the federal government back to us as quickly as possible. And that just seems to be, to us, the biggest administrative burden that we've taken on through that.
And for us, the biggest wake-up call was our inability to produce estimates effectively and efficiently, right? So then just looking at technology, and I mentioned earlier, right, when we internally can use one back-end facing portion of our tool to type in the CPT code and get that information because it's integrated with Cerner, that comes up pretty quickly. But to have something patient-facing or something that's less known, I'm coming in for an office visit, but I don't know if there's going to be labs or other diagnostics on that. What's that going to cost me? How can you answer that question? And I think it goes back to what Ashley was saying, setting those expectations. It's a little bit, and then a secondary thing on the back end with all of our partners is, and it might be a little bit easier for us in rural America, but we, aligning all of our products and plans with those radiologists and outside anesthesiologists, any outside payer, right? Here's what we're in, and as part of the contracting, as you're working with them to, come provide services to your organization, ensuring that you're limiting the amount of out of network situations that you can run into, and having them get enrolled in similar plans and helping them with that enrollment process. Would be some preventive measures that you could go about.
Yeah, one of the things that we had talked about with the No Surprise, especially since patients don't necessarily always have those CPTs, is a lot of times what ends up happening is we have a good idea of what's going to happen, but something, during the procedure changes and, the coding is a little bit different, and the CPT code that was what everything was quoted on doesn't end up being what the end result was. And that can be something that can be a little challenging too, is, patients are thinking, this, and all of a sudden now you've got that. So it's not a exact science, but I think we've come a long way from where we were prior to the No Surprise Act coming into existence. So I think it definitely has helped at least give them a little bit more of an understanding rather than opening up a bill and going, oh my goodness, what just happened? So that
I think communication, right, around like, this is an estimate, like this is not, if there, this is what could change, and this isn't because we're trying to rip you off or we're trying to, but again, we want to be transparent. And I think it's, whether we're talking about patient, focus groups or patient, whatever that looks like, of how are you communicating that? And is it something that's digestible and understandable to the population that you're trying to reach? We're doing our best. And, I know different estimator tools have ways of looping in that historical data. So if you're saying, a colonoscopy, this is the typical CPT code, and here are the add-ons for anesthesia and other things. And so we're able to give you, as a starting point, and then you can continue with the system to build in, okay, historically, these were the add-ons. So like we're getting better and better, and hopefully with, different EMRs that's you're getting that ability to get smarter as you continue to work with estimates in your system. But again, just trying to explain to the patients that, this is what an estimate means. This is what we think it's going to be based on, what the doctor's ordered or historical, or just, again, when you're doing shopper estimates, this is just what it typically is. But here's how this could change. And again, it's not because we're trying to trick you, but just being, I feel like I keep saying transparent, and that's like feels a little cliche at this point, but that we are being transparent with you on what you're looking at.
Yeah, one of the things that I really liked when you had mentioned those focus groups is it almost is like we are partnering with other departments. I think of marketing, for instance, to try to use what they would typically use a focus group for, to kind of help us on the revenue cycle side, help our patients from a different perspective. So it also helps us collaborate with other areas within the hospital, so that way we can ultimately achieve what our end goal is, which is helping the patient. The next question we have are social determinants, are unavoidable considerations, particularly for those in serving, populations. I think of things like immigrants, elderly, inner city, or rural communities. Have any of those factors helped shape your approach, and or particularly as a driver of innovation or as a limiting factor due to fundamental access constraints?
Yeah, over the last 3 years, I'd say that we've gotten much more scientific about social determinants of health. We've actually created a healthcare disparities committee to make sure that we have the resources available to meet the need in our community. And we've also tried to use technology to match our patients up with resources that are available. We have a very strong community in Houston with lots of resources, but being able to match the patients to the needs that they have has been a little bit of a complex task. And the third thing I'd like to point out that we've been doing is really taking advantage of the Z codes for the social determinants of health, and making sure that our case management and social work team are getting that information into the medical record so that we can really show the complexity of the population that we're taking care of. We've used technology to help us with that as well.
Something that we initially struggle with is, there's a lot of great screeners and assessments for social determinants of health, but what do you do with that information? Do we have a responsibility? If we don't have that back-end infrastructure, Linda mentioned, right, connecting the resources, if we're not as robust as we'd like to be over there, what type of liability are we at if we screen for various factors? One of the brightest things that I think came out of the pandemic was telehealth, right? So again, taking care outside the four walls, and no longer 9 to 5 at my time, but when is it most convenient for the patient? And that is some of the first steps we're taking to meeting patients where they're at, and then screening them and identifying their needs and shifting some of those assessments pre-service so that they can get those done. And patient-centered medical homes. I think we're starting to hear a lot more of those popping up. We've got one in a pediatric clinic, a nationally recognized one we're quite proud of, that's got a social worker embedded in the clinic. But to know what to do, you've got to screen, and then you've got to connect the resources. You've got to have those partnerships with the downstream community-based organizations to close the food insecurity gaps or the housing gaps or the rent assistance. But it's all about getting those resources and care out, putting them in the hands of the patient, letting them decide what to do with it. Something that we're just now starting to discuss is after an inpatient discharge, if we identify that food insecurity is an issue, sending the patient home with how many ever meals, if that's one meal a day's worth, a couple days worth. The healing process is not just medications and rest, it's what you put in your body. And so how can we support that, going far beyond just the medical care, but having not a one size fits all, but understanding the lifestyle, understanding the household dynamics to develop that tailored solution. You can't improve what you can't measure, but you got to measure it and then make sure you've got the ability to act on it. So.
Yeah, I think that approach of meeting patients where they are really is key, and something that we've got to kind of keep in mind of, that the saying that goes on the wall of your patient population is very different. And, we're in New Orleans, so we've got a very diverse population. We serve, we've got inner city, we've got children, we've got an indigent population, we've got a large, both Spanish speaking and Vietnamese population. We've got a large elderly population. There is not a one size fits all for any of this. And I think really understanding, okay, who is this patient, and putting that in a patient-centric way, and not just on the patient care, meaning the clinician side, but even on the access side, and figuring out, how do we tailor this? How do we make sure that when the patient comes in, that they have something that they can read, that they are hearing the language that they know, that we're helping them, and we're able to provide, again, whether that's that smile, that comfort of that healing process that starts right there. One of the things, just for this, how these different social determinants of health have shaped our approach. And when I'm talking about the different innovations, we had a lot of pushback when we started to roll out our robust online scheduling program of, this does not work for elderly patients. This does not work for an indigent population. This does not work for kind of put in any group of patients that's not the 25 to 45 college educated demographic. And we've been surprised. We're kind of at an age where almost everyone's got a smartphone, and almost everyone has access to the internet on a phone. And the amount of people and the different populations that have utilized MyChart or have utilized online scheduling for their own convenience really has surprised us. And so I think both making sure that you understand your population, but also putting some trust and some faith that it's not just the standard groups of people that you expect to use some of this technology, that there is a lot more availability than we're thinking of, just people that are sitting at home with a PC in front of them that can use these online tools, and that can utilize your kind of EMR and the electronics and the different neat things that you have available for your patient population.
And I think, to add to that, provide the patient the choice. Allow them to make the decision how manual or automatic that they want to go with that. And I think that's something that we've really seen in technology. The technology that you have as a choice determines how a patient views their experience at the hospital in some cases. If it's too hard, if it's, it might be, this is too good to be true type situations. But a lot of times this may be, it's too hard to do, I'm not going to come back, because this seems like this is the only way to do it, I'm not coming back. Then you have some that if your technology is not robust, then it's, you must not be cutting edge. So maybe we don't, maybe the provider or the facility isn't thinking forward about things. So certainly, having those choices for patients to be able to pick from.
Yeah, that to relate to that, Ashley, it's as many different entry points as possible. If they want call, you have call or text or email, face-to-face, virtual. One of my colleagues used a word I liked, omni-channel, right? As many omni-channel options to patients. So I totally agree with that. And then Kaylin, earlier you talked about self-scheduling. I think that you see that in every patient access journal that you're reading and what's going forward. I'm asking now for help over here. What advice and tips do you have for self-scheduling? Right now we're looking at, all right, well, we've got a same-day appointment slot in the morning and one in the afternoon. Maybe we just open those up to self-scheduling, right? Maybe patients don't understand how to use it. And do you have any advice for anyone looking down that path?
Yeah, this would be a whole separate conversation, and we'd be happy to connect on this, because it's definitely been a journey. But I would say provider buy-in up front, having a really good physician champion that believes in this, that believes in patient scheduling, having good reporting that shows you that this is not disrupting your healthcare system. There's so many awesome metrics that you can see, like the amount of money that you're saving by doing this, by really opening up the schedules, by, looking at the data doesn't lie. And so when you look, kind of, we've gone specialty by specialty, and, it's a bit of a blind faith. We started with primary care, which was kind of our easiest to go into, and we're now in our 6th wave. But it's, again, the data doesn't lie. And when you start to measure, okay, how many of these appointments are being scheduled, and we've opened up the schedules, our providers are better utilized. Our patients our no-show rates have gone down, because again, now the patients are not relying on having to talk to someone to either cancel their appointment or get in the door. And yeah, the numbers continue to go up. And so it's, I think, getting a good ground team, a good core group of people that believe in it and can push this out. Providers typically are the biggest hurdle and roadblock, but yeah, ultimately from a patient experience and just from a financial experience, it's been a huge hit.
Thank you so much for that.
Yeah, one of the things that, being an inner city, we are in the city of Detroit, that we have kind of looked at is we've got a homeless population, we've got elderly, we've got a lot of nursing home patients. There's a variety of different patients that we serve, but we looked at, tablets, for instance. So some of the people, when they're doing their check-in, didn't opt to use their phone, but we have tablets for them so they could actually do that instead of having to, formally sit with a patient, access rep and go through everything where we can provide resources for them at the hospital even to help, kind of participate so they don't feel left out. And that has actually worked for some, patients. The bigger, screen size rather than it being, just their phone. I've actually been in one of our offices, and I saw the patient access rep, working with a patient, taking the time and explaining everything. And what we found is, when you take the time, even if it's up front in person, and you can explain what's going on, why we're offering these solutions, patients are a little bit more engaged as well, going, oh, I understand, and I can do this going forward. So the next time that they're at the office, it speeds up the whole process because they've already done it once. Depending on the situation and the type of clinic, those are also things that we've been able to employ that has been able to help patients. Does anybody have any thoughts before we wrap up? I really thank you guys so much. It's been a wonderful talk that all of you guys were able to contribute to. At the end of the day, we're all here to help patients, be the best that they can be on their healthcare journey. So everything that you guys talked about and the experiences you guys have at your hospitals, I think will help, people as they continue the journey with their patients. So thank you guys so much for your time. I really do appreciate it.